Okay, so welcome to our lecture on Chapter 3, Inflammation and Tissue Repair. This is going to be an important chapter for you all moving forward, basically knowing and understanding these different processes and timelines for soft tissue healing, bone healing, and some of the physiologic responses that we're expecting to see here. So some of the objectives: describe the mechanisms of tissue injury and repair. That's going to be our main focus through this chapter. In the lab setting, we're also going to look at demonstrating competency in identifying normal and abnormal changes in the integumentary system, something that we've already been doing through our cryotherapy, through our thermotherapy modalities and applications. We're going to continue to move forward with identifying abnormal changes, normal changes to the skin, pre and post modality application. We'll also talk about when an intervention should not be performed due to clinical indications or contraindications. When an intervention is beyond the scope of the PTA, and when to report those changes in patient status or progress to the supervising physical therapist. So these are some of the main topics that we're going to be covering. We're going to definitely look at the inflammatory process and all the different physiologic responses the body goes through during that phase and during the reparative phase as well. We'll talk a little bit about acute versus chronic injury. We've done that in the past already, but it's important to understand and realize the processes, what's happening physiologically so that we can make the best clinical judgment for our modalities and for all of our interventions. We'll talk about the elimination of pathological and physical insults. We'll talk about the replacement of damaged or destroyed tissues and promoting regeneration of normal tissue structure. So something that you probably have already covered in your fundamentals of disease course, your pathology course, but we're going to look at a little bit deeper today in my class. So you need to know these timelines for these different phases of inflammation and healing. So when you're looking at the acute inflammatory phase, we're looking at days 1 through 6. For the proliferation phase, we're going to be looking from days anywhere 3 to 20. And the maturation phase, days 9 and moving forward. So you can kind of see here that these phases can vary in duration and they do overlap. So it's not always going to be 1 to 6 days. It's not for the inflammatory phase. It's not always going to be 3 to 20 days for the proliferation phase. They may happen sooner, they may happen later. So again, that's why it's important that we note the skin integrity, the changes, the abnormal and normal responses to our interventions that we're performing with our patients. This is kind of the path that we're going to look at here, starting at the very top, moving all the way down to the bottom. So this is a nice little chart that kind of represents all of the different phases that we're going to be talking about through the inflammation phase, vasoconstriction, dilation, clot formation, phagocytosis, into the proliferation phase where we see epithelialization, fibroplasia, collagen production, wound contractures, neovascularization, all the way into the maturation phase where we start to see collagen synthesis, collagen fiber orientation, and then we finally get to that healed injury. So we're going to go over in more detail on these next upcoming slides all of those phases. So just a different chart where you can see kind of those time frames for the inflammation phase, the proliferation phase, and maturation phase. Again, just important to note that they do overlap at times, and it's not always going to be the exact same time frame that you're seeing for every patient that walks through the door. Okay, so let's look at this inflammation phase. So what does inflammation really mean? The Latin term for that, inflammer, means to set on fire. So we're going to see these different signs and symptoms that pop up here and maybe why that's appropriate to name it that way. But what's the goal of this inflammatory phase? Well, it's really to destroy, dilute, or isolate the cells or agents that may be at fault or maybe have caused the injury. It's important to remember that inflammation is important and necessary for healing. We need to go through this process in order to have normal healing, but it can be harmful in certain instances, like when we see rheumatoid arthritis and some of these other kind of common autoimmune or inflammatory pathologies. So rheumatoid arthritis being one of them, diabetes Type 1 would be another. Systemic lupus, Graves' disease, aka hyperthyroidism. Those are all ones that can be harmful, right? That's a chronic type of inflammation in the body that is not there to just promote tissue healing. So the common signs and symptoms, you may already know these, but we have heat. So palpation is going to be really important whenever you are assessing your patient's skin integrity. You're feeling for the heat differences between the affected and unaffected side. You also want to note if there's any redness in the area compared to the unaffected side, if there's swelling, if there's pain, or if there's any loss of function. Those are the signs and symptoms that we're looking for. Just remember that a clinical sign is something that you can observe, right? So you can definitely feel heat with your hands. You can see redness. You can measure swelling. And that's something that we're going to be doing a little bit later on in the semester and into semester 3 and 4. We're going to show you the best techniques for how to measure swelling in the limbs, get these girth measurements. So we're going to look at that in more detail in the following semesters. But we're also going to ask those subjective questions: pain, loss of function. We may be able to identify and kind of observe some of these loss of functions that your patients are experiencing, but we do need to get that pain scale, 0 to 10, 0 being no pain at all, 10 being the worst pain. How do you feel right now? How do you feel when you're performing these certain activities? What makes it better? Those are all important questions that we're going to ask in this phase. So besides physical therapy management, we can definitely treat inflammation with a cold pack like cryotherapy, like we've seen in the past. We can use different forms of e-stim to help eliminate swelling in certain areas, or maybe change the tissue charge in order to promote healing in a more positive way. But those are all kind of what we're going to be doing as physical therapist assistants. But we also need to look at the pharmacological management here. So the two that I really want you to know would be these NSAIDs, non-steroidal anti-inflammatory drugs, such as ibuprofen, such as naproxen, aspirin, diclofenac, and also corticosteroids, prednisone, dexamethasone, hydrocortisone would be some of the more common ones that you would see. And we'll talk about dexamethasone when we get into our ultrasound unit, because that is a really common medication that we'll use with phonophoresis to kind of drive that medication through the tissue and to promote decreases in inflammation. So not only do we need to know which medications can help treat inflammation, we also need to know what the patient response is going to be and what some of those adverse reactions might be that we can notice in clinic, that we can educate our patients on. So when we look at NSAIDs, our pain tolerance during exercise is going to go up, because this is here to help decrease pain and inflammation. So if somebody's taking, some of those medications that we just talked about, you want to be really cautious with overuse during your sessions. You don't want to push too hard, because once the NSAIDs wear off, once they leave their session, their pain tolerance may return to its kind of baseline, and now they're in more pain than they were previously before the session. So you want to be really cautious with your exercise dosing, your range of motion activities, things like that. So you just want to be aware of it. Something else that you need to know about these NSAIDs is they do have the ability to cause these gastrointestinal ulcers or stomach pain, and they also have an effect on soft tissue healing. So it actually delays that process. So you may be asking yourself, well, how does it do these things? Why do GI ulcers form? Why do these NSAIDs really delay soft tissue healing? Well, let's just look at the stomach ulcers first. Whenever we have prolonged use of NSAIDs, these NSAIDs have very different type of effects on the body. So the main thing that you're looking at is they inhibit the production of these prostaglandins, and those are really critical for the inflammatory phase of healing, so we'll look at that with soft tissue healing, but they also help stimulate mucus and bicarbonate secretion to protect the stomach lining. So if we are inhibiting those with the use of prolonged NSAIDs, we're actually decreasing their ability to produce that mucus to protect the stomach lining. They also damage the lining of the stomach just by being weak acids in themselves. So not super great to have prolonged periods where you're taking NSAIDs for the stomach for those reasons. And very similar whenever we're talking about the prostaglandins inhibition for soft tissue healing. So again, those are critical for initiating the inflammatory phase of healing, which improves blood flow to the area, which improves capillary permeability and cell permeability. So if we're inhibiting all of those actions, we can delay the soft tissue healing from happening because it's not going through that inflammatory process. Okay, let's move over to corticosteroids. So some of the things that you need to be really, really cautious of is you want to monitor your patients for overuse if they're taking these corticosteroids for prolonged periods of time, because it weakens tendons and bones. Okay? It can also suppress the immune system, cause depression, and cause weight gain and edema. But let's talk about the main thing that I really want you to focus on here is the weakening of tendons and bones and why that happens. So corticosteroids, they decrease the activity of osteoblasts and fibroblasts, which, if we know what those two do, they help promote bone growth, they help promote collagen production, and specifically for collagen production, that's the main primary structural protein in tendons. So if we have decreased ability to produce more collagen, obviously that's going to weaken the tendons and their ability to recover from any type of injury or micro damage to the area. Corticosteroids also increase enzymes that degrade collagen. So we're really trying to stay away from overuse of these specific high intensity exercises when somebody is recovering from an injury. So we have to be really cautious and we have to be aware of what medications our patients are on. Again, corticosteroids being one of the main ones here because we don't want to cause tendon ruptures. Let's say like somebody is recovering from an Achilles tendon injury, they are prescribed some form of corticosteroid like hydrocodone, and you're going through some pretty intense single leg, eccentric, lengthening type strengthening activities, and that tendon snaps on you, right? Maybe that's not the most appropriate thing to do for somebody in their phase of healing with that consideration that they're taking corticosteroids, especially for long periods of time. So if you have any other questions regarding, NSAIDs, corticosteroids, their effects on the body, the reasons why we need to be aware of those, just reach out to me directly. The next slide here just shows a few different examples of, what you might see during this inflammatory phase, okay? So we're looking at the top left corner here. This image shows, you can kind of see it on the left-hand side of your screen. Somebody had a knee replacement. You can see that nice incision. And now they have a second knee replacement on their left side or our right side of this image. So the staples are still in. That means they're still within 7 to 10 days essentially of surgery. We usually take them out at 7 to 10 days or so. So they're still in there. You can see the differences in color of the affected leg, the one that still has the staples in. More red in appearance, even though the unaffected side still does look partially swollen. There looks like there's quite a bit of edema in that area or joint effusion. You can still see that the affected side, the one that's most recently gone through surgery, is much larger. So what we would do is we would take the tape measure and we'd measure the girth of each limb and compare them side to side. And then we would see if our interventions like applying a cold pack or elevating the leg or using some kind of vaso-pneumatic device, ice with compression, would actually improve the swelling in the area. So you typically want to take a measurement before any of the modalities that you're performing your interventions, and then you'd want to take one after the fact too, so that you can prove that those modalities, those interventions are working. We need to justify in our documentation why we're doing certain interventions, and that's one way that you could do that. Same kind of thing that you see on the image on the right here. So it's kind of hard to see in this image, but you can see that there is some staining of the skin, which we will look at in greater detail, especially when we're talking about venous insufficiency in our pathology course. But you can see that that right ankle is more swollen. Same kind of thing that I just mentioned with the total knee replacement. You would want to take a measurement pre and post intervention to see if any of the modalities, activities that we're performing are working. And then the last one on the bottom here, we're just looking at that middle finger right through here. So you can kind of see in that proximal joint right in the middle, very swollen, very red, especially compared to the other fingers. But those are some of the signs that we're looking for whenever we're assessing if a patient is still in that inflammatory period. We have swelling, we have redness. What you're probably going to see is decreased function or loss of function, as well as pain associated with those. Okay, so I threw this in here because it's really important that we know the different types of exudates as well. So anything like drainage, like let's go, if we could go back to that previous slide and we were looking at the patient that has the total knee replacement, pretty common to see drainage coming out of that incision, especially as it is being moved around as soon as your patient starts to perform more knee flexion, things like that. It's really common to see different types of exudate, and we just need to know which types of exudate are normal and kind of healthy responses versus some that are not normal and not healthy responses. So let's just take a look here really quickly. Let's look at the very far right side, types of exudates. The first one that you see there is serous, which is clear, thin, watery, typically just plasma. That's normal. That's what we want to see. That means that everything is healing properly. That's kind of like what we're hoping to see whenever we are performing bandage changes, when we're assessing any type of incision or open wound. The next one down is serosanguinous, which is thin, watery with a light red or pink hue to that. So that just means that there is some blood in that serous type drainage as well, which is typically fine. Again, those first two are probably the ones that you're hoping to see whenever you're performing those bandage changes. But as soon as we get down to sanguinous, which is bright red, flesh blood, or purulent, thick, opaque, odorous, those ones we need to be really aware of and monitor closely, and probably refer back to our supervising PT just to say, hey, look at this drainage, come look at this wound with me here. This doesn't look normal. So if we have that sanguinous, that really bright red type exudate drainage, that may be indicative of hemorrhaging going on inside the tissues, which is, showing up on our pads, essentially our different types of dressings. So there's a lot of bleeding going on. Not good, right? Not good. The worst one out of all of these, maybe not the worst one, but one that you really need to be aware of for sure, is this purulent type exudate or drainage. Again, that thick, opaque, odorous buildup. This is typically associated with infection. Okay, so if you see this type of drainage, you're probably also going to be assessing the limb. It's probably going to be bright red. It's going to look inflamed. It's going to look like it's infected. So purulent is the one that we absolutely need to be aware of, because if we don't catch an infection, then there's a lot of different and bad things that can happen. Somebody could get some type of systemic infection, and that's not good, right? We don't want to lose a limb because we missed something that was infected. So just remember, those first two are the most important ones. All right, so now let's talk about these different phases, or these different responses in this inflammatory phase. We're going to go through the vascular response first, followed by hemostatic, cellular response, and then the immune response. So let's look at this vascular response first. So whenever we first have an injury, there's a few things that happen first. Initially, we see vasoconstriction in the area, which is narrowing of the blood vessels. That helps to minimize blood loss. And that lasts for about 5 to 10 minutes. Then immediately following that, we also see an increase in vasodilation and increased cell permeability. These are the undamaged blood vessels near that injury site that dilate to improve blood flow to the area, which is going to allow for a lot of these other types of nutrients and immune cells to enter the area to start targeting some of those injurious agents in the area. So that cell permeability is really improved by the introduction of histamines and those bradykinins, and they last for about an hour. Okay. Then we see edema form as a result of this cell permeability. So as those capillaries open up, we tend to see plasma leaking out of the red blood vessels and accumulating in those tissues where there is an injury. So that's essentially what's happening. Within that first hour, we see, again, the vasoconstriction first to limit blood loss, and then the uninjured cells around the injured site, vasodilate to help improve blood flow to the area because we're trying to deliver nutrients, white blood cells, all those kind of things to the area to start debriding essentially the infectious agent or that injurious agent in the area. Because we see that capillary permeability increase, that's when we start to see the edema forming in that injured area. And one of the last things that happens here in this inflammation phase is what we call chemotaxis. So what is chemotaxis? Basically, it's a call for help from your body, right? This helps to attract white blood cells, leukocytes to the injury site. And those leukocytes, as you've already learned, play a critical role in fighting infection and cleaning up debris. So we're going to look at a little bit more detail of that whenever we get into some of these other phases or these other responses in the inflammatory phase. And then on this next slide, we have a nice little diagram of essentially that first response to what's happening. So we see this nice little blood vessel here in our image. We see our red blood cells. We see kind of these little gaps forming as well. So at the very top of the page, you can see it says separation of endothelial cell junctions, creating gaps, allowing leukocytes to escape. So those leukocytes are escaping our blood flow essentially, or the bloodstream, and they are now entering into the area where that injury has happened. Also, the plasma that you see right underneath it is what is also going to leak out due to that cell permeability, and that's going to form in the surrounding tissues, which leads to your edema formation. So if you want to think of a simplified takeaway from this first phase of the inflammatory response, this vascular response, it's like the body sending reinforcements to help heal the injury. First, we're going to see it vasoconstrict to stop the bleeding, and that's through the damaged cells. Then the undamaged cells, the healthy cells, are going to vasodilate, basically opening the floodgate to help send these immune type cells and nutrients to start the repair process. So it'll be really important to know that vascular response. If you have questions on that, again, feel free to reach out to me directly. So let's move into the next response of this inflammatory period or this inflammation phase called the hemostatic response. So basically what the hemostatic response is a way for the body to control blood loss when those vessels are damaged. Initially, we saw in the vascular response, we get that vasoconstriction of the damaged cells in the area, but this is on a little bit greater scale here. So and if you just think about what the word hemostatic means, hemo, blood, static, stop, that's just exactly what it is. We're trying to stop the amount of bleeding in the area. So there's a couple other things that you need to know from this phase here. Platelets enter the area immediately and they release fibrin and this PDGF, or platelet-derived growth factor, to help stabilize the wound. So this is basically the platelets forming a temporary plug at the injury site. And it's using that fibrin and that platelet-derived growth factor to kind of help stabilize the wound. Then we move into that next little piece there where the fibrin and fibronectin form crosslinks with collagen. So we're basically forming this nice fibrin network. And just remember that fibrin and fibronectin are proteins, okay? So they're going to form this nice sticky web, or if you want to think of it as like a scaffolding over the injury site, that's what their job is to do. And that's going to help promote kind of like a building site for further collagen when we get into some of these other phases, okay? So they're forming this nice little scaffolding over the injury site. And this helps to form crosslinks with collagen again whenever we start producing more collagen to help temporarily stabilize this wound. And again, stop further bleeding from this area. The other thing that you also need to kind of keep in mind here for this hemostatic response is, yes, it's going to help limit local bleeding and fluid drainage. So we're trying to limit the amount of edema forming. We're trying to limit the amount of local bleeding in that area. But it's also going to help confine that inflammatory reaction to the injured site. So we don't want this inflammation spreading throughout the body. We want it to be very specific and stay in the area where we actually need this inflammatory response. So another simplified takeaway for this hemostatic response is our body is building a temporary wall essentially to stop the bleeding, protect the injured area, while also setting the stage for healing. So we're trying to build this kind of cross-link fibrin collagen network so that we can further build proteins on top to really close that wound. And I've got a nice little image here, pretty cool little image. So you can see this fibrin network really taking place. So it kind of looks like a spider web, right? We see all of the red blood cells. They're trying to exit the area of injury. We get that fibrin and that fibronectin forming that nice little lattice or scaffolding to help limit the amount of bleeding in the area, limit the amount of plasma or fluid leaking out of that area and spreading to further portions of the body. Okay, now on to the cellular response. So the cellular response really involves like a coordinated action of these various different blood cells, red blood cells, white blood cells, platelets, to kind of help manage the injury and start that healing process. And if you think about what the role of red blood cells would do, their main job is really to deliver oxygen to the tissues, which is essential for cellular repair, energy production at that injury site. We get the leukocytes, or those white blood cells, which are basically the defenders, right? They come in and they fight infection and help clean up debris in that area, so the infectious agent that maybe entered the area. And then the platelets, again, we talked about them in the last little response there, in the hemostatic response, help to reinforce the clot to prevent further bleeding and release chemicals to help promote that repair. This is where we also might see hematoma formation or hemarthrosis formation. So hematoma is blood pooling outside the blood vessels, kind of like a bruise at the injury site. And when we talk about hemarthrosis, you could probably break that word down and get an idea of what might be happening there. This is when blood pools inside a joint, which can definitely happen after injuries to ligaments or cartilage or something along those lines. These processes can also contribute to more swelling in the area. Then we move on to what we call phagocytosis. So you've learned about this probably again in your fundamentals of disease class, so you should kind of have an idea of what this process looks like. But essentially what's happening are that neutrophils enter this site. They're kind of the first responders in this cellular cleanup process, if you will. Their role is really to engulf and digest debris, bacteria, dead cells, so those kind of things. So neutrophils are really important in that phase. Then we get down to this last little piece here, this last little bullet, where it talks about monocytes and macrophages. So monocytes are just white blood cells that are like rookies, I guess, in the cleanup team. When monocytes enter the injured tissue, they transform into macrophages, which are more powerful cleanup cells. So we have the neutrophils kind of getting in there, debriding the really large tissue, killing some of those infectious agents that might be in the area. And then the macrophages come up and they also kind of take what's left, essentially. So whatever the neutrophils missed, or whatever they missed, whatever might have gotten past their walls, essentially, the macrophages clean up, and then they release growth factors into that area to stimulate tissue repair. So cellular response is really big. Think about that cellular response as these white blood cells kind of entering that area, starting this process of phagocytosis with the neutrophils going in first, right? They engulf and digest debris, bacteria, dead cells, and then the monocytes enter into, they kind of leave the bloodstream. Once they leave the bloodstream and enter into the area, they become macrophages, and they are more powerful cleanup cells. So they're going to get whatever's left that the neutrophils may have missed. And this next little slide just kind of shows what a macrophage does when it enters into the area where there is injury or some kind of infectious agent. You can see that macrophage kind of going towards the debris, engulfing it, and then it finally kills it, gets rid of it, and that's really the role of the macrophage in that cellular response. All right, so let's get into this last response of the inflammatory phase, called the immune response. So something that we have covered already in our fundamentals of disease course would be the idea of what we know as cellular mediated immune response, or immunity, as well as a humoral response. So let's just kind of talk about that cellular mediated immunity first. So the cellular mediated immunity introduced what we call these T lymphocytes, or T cells. And remember that these cells attack and destroy anything that looks harmful, pathogens, damaged cells, things like that. But they are also non-selective. So T cells don't target specific invaders. They just focus on any abnormal or infected cells to kind of protect the body. So we'll see a little bit of a difference when we start describing this humoral immunity. So remember that the humoral immunity introduces B lymphocytes, or B cells, into the area. And remember that these ones produce antibodies, which act like tags, essentially, that mark harmful invaders like bacteria, viruses, things like that. So it's important to remember that we are creating antibodies with this humoral type immunity. These antibodies are proteins like that are specialized weapons tailored to neutralize specific threats. And then they form memory cells. These cells remember past infections because of that tag, making the immune system respond faster the next time that same invader shows up. And there is something that we call the complement system. So they work alongside each other, the cellular mediated and humoral response, to amplify the effects, help destroy invaders by punching holes in membranes or marking them for destruction by immune cells. So again, really important to note that these T lymphocytes enter the area where there's an infectious agent, and they're just looking for anything that looks abnormal. But those B cells, when they come in there, they're looking for very specific type cells. Okay. So a little simplified takeaway here for this immune response is the body security system essentially introduces T cells acting as the attackers first, B cells building kind of these specialized weapons to kind of help find those cells that they are already recognizing. And then the complement system providing extra backup essentially to ensure that all of the threats are eliminated in that area of inflammation. So just remember here for the inflammatory phase conclusion, all of those different responses are part of the inflammatory phase. Okay, so we have the vascular response, we have the hemostatic response, we have the cellular response, and the immune response. So you'll need to know all four of those responses as they relate to the inflammatory phase. And you just need to know kind of what the purpose for this inflammatory phase is. We're trying to form a fibrin lattice, basically limiting blood floss, provide some initial strength to the wound so that we can stabilize it. We're removing damaged tissues in the area, trying to limit infection, and we're also recruiting endothelial cells, fibroblasts, to help spark that next phase of this reparative process. So now let's move into the proliferation phase. So essentially what's happening in this proliferation phase is the wound is being covered, the injury site regains its initial strength, and we're going to talk about these four concurrent processes in a little bit more detail, but we first have epithelialization, collagen production, which we're going to talk about granulation tissue and what that presents like and what it looks like. Then we also have wound contraction and what we call neovascularization. So the first two we're going to look at, epithelialization, basically is the process of regenerating the outer layer of the skin. So this forms a barrier to prevent further fluid loss, electrolyte loss, and it protects that wound from any further infection or injury to that site. This barrier is supported by collagen, which gives the tissue structure and strength. Okay, so then we get into the collagen production, which we're going to see this ascorbic acid, vitamin C, is completely essential for the formation and the structure of collagen. So we can always educate our patients on, making sure that they have an adequate amount of vitamin C in their diet, things like that. But we're also going to start to see this granulation tissue form in this phase. So basically what this is new, healthy tissue, which is going to appear red or pink due to the new growth of blood vessels. So we really want to see granulation tissue forming in a wound bed to ensure that it's healing correctly and properly. We again don't want to see any of those other drainages that we talked about earlier, like purulent or straight sanguinous, right? Because those are indicative of either infection when we're talking about purulent, or hemorrhaging under the skin if we're thinking of that sanguinous type drainage. So the next process that we're going to talk about here is wound contraction. So basically what's happening here are the edges of the wound are pulled together to reduce the size of the injury. And there's specialized cells called myofibroblasts that are responsible for this contraction. One of the key benefits here, obviously, is that the process minimizes the area that needs to heal, which will speed up that wound healing time or recovery time. I do want to talk to you about healing by primary intention versus secondary intention as well. So with primary intention, this type of healing, the wound edges are directly pulled together using sutures, staples, adhesives, something like what we saw earlier with that total knee replacement. This is basically, when there's minimal, using this type of healing intention, this primary intention, limits the amount of tissue loss and it has a much lower risk of infection. So again, think of like that surgical incision that we saw earlier with the knee replacement. That would be considered healing by primary intention. Then we get to secondary intention. So the definition of this is for this type of healing, the wound is left open and must heal from the bottom up through granulation tissue formation. So this could lead to significant tissue losses if those wound edges cannot be approximated and closed. But typically you're going to see this with like irregular type wounds, not something that's a straight cut or something that you would see like with a surgical type incision. Also, if you think about, we're just leaving this wound open, this is going to be exposed to the environment, and it requires a much higher immune response from your body. So the risk of infection is much greater if we choose to go through this secondary type of intention. And an example of this would be something like a pressure ulcer or some kind of traumatic wound. So again, think of something that's not regular, right? It's kind of an irregular shape to the actual wound bed itself. And the one that I didn't have on that slide is what we called third intention or delayed primary closure. So this one is a little bit different. It kind of combines some of the different methods from primary intention and secondary intention. And the reason that they would do something like this is that they need to clean out the debris or the infection, necrotic tissue first, reduce swelling, contamination, all those things, before they go in and try to suture it together. So you can kind of see this image on the left-hand side. You can obviously see that it's not completely closed and it's not approximated like you would see in a normal healthy wound. But they probably went in there and they cleaned it out as best they could. There still looks like there's some necrotic tissue or slough in the wound, but who knows what it looked like before, right? So they went in there and they cleaned it out. They allowed some of that granulation tissue to form via secondary intention first, and now they applied some sutures to the area. And this would be kind of your third intention or delayed primary closure healing. And the last process that we're going to talk about in the proliferation phase is something that we call neovascularization or angiogenesis. You can use those terms interchangeably, but this is basically where we're seeing the new formation of blood vessels in the wound area during this phase. So the purpose here is to supply oxygen, nutrients, which are essential for healing, and we're also trying to remove waste products from the wound site. So basically what's happening is that we start to see these new vascular networks forming. So we have these tiny blood vessels sprouting from pre-existing ones, creating a new network essentially. This term anastomosis is the formation of new vessels and essentially connecting to existing ones to ensure efficient blood flow to the area. And then we get coupling of those vessels. So the new and old vessels integrate, they stabilize blood flow and promote healing of those tissues. You can kind of think of angiogenesis as kind of like building new plumbing for the healing site. We're bringing in supplies, the nutrients, the oxygen, and we're taking out waste with this. And this is a really essential part of what promotes that granulation tissue that we discussed earlier. Without angiogenesis, granulation tissue really cannot form properly, and this would slow down the healing process. So a little bit shorter for the proliferation phase, not quite as detailed as what we'd see for the inflammatory phase, but still going to need to know the term angiogenesis. You're going to need to know what granulation tissue is supposed to look like. You should probably know that vitamin C or ascorbic acid is really important for collagen formation and structure. So those are kind of some of the highlights from that proliferation phase. Now let's look at the maturation phase. Just remember that when we're looking at our timelines, this is something that could take place as early as 9 days, but between 20 days. And it could extend far beyond that, just depending on the injury severity, where the injury occurred at. All of those things kind of play a factor into how long this phase really is going to last. But you're going to see changes in size, form, and scar tissue strength in this phase. So if anybody's had an injury, which I'm sure we all have, you'll notice that some wounds, they heal really well. You can barely even see where the wound was previously, and then for others, like bigger wounds, bigger traumatic type injuries, surgical scars, that skin is going to be, altered permanently. That's why we still see that scar, years later down the road. Again, remember that this maturation phase can last a significantly long time. It can persist longer than a year, especially if we're looking at injury to structures like ligaments, tendons, and those kind of things. Typically, soft tissue, skin type ulcers, wounds, things like that, they typically will heal fairly fast, but it depends on a lot of different factors. Does this person have any comorbidities, decreased circulation in the area? All of those things kind of play a role in, how fast this maturation phase gets to the end life, essentially. We can also start to see the formation of keloid and hypertrophic scars. So what are those? Keloid scars are, it's basically scar tissue that grows beyond the boundaries of the original wound, and we'll look at a picture here in a second. And hypertrophic scars typically do not extend beyond the boundaries of the wound, but you're going to see kind of what these look like here in just a second. So you can kind of see this nice keloid scar here. It's going to be raised. It's going to be darker in color, right? And it grows beyond the boundary of that original wound. The hypertrophic scars do not extend beyond, but you can still see the differences in what normal healthy tissue looks like and scar tissue, right? Just remember that when we talk about scar tissue, whether it be on the skin, in the heart, wherever it is, that tissue is not going to act like normal tissue. It's not going to have the same sensation. It's not going to be as elastic to stretch and different changes. So we want to do everything that we can to limit the abundance of scar tissue after certain types of injuries. Which brings up our next slide here that we call the tension theory. So whenever we get to this maturation phase and we see significant strength in the wound bed, we're not at risk of rupturing the wound or causing a new injury to the area. We really want to provide some type of internal or external stress to the area, especially as a PTA. We're going to be focused on kind of that external stress, but we want to really ensure that we are stressing the tissues appropriately so that they lay down collagen fiber in a formation that's going to promote elasticity but also strength. So when scar tissue heals, it's usually in a very random orientation, which doesn't allow for strength, it doesn't allow for elasticity. But if we take a patient, let's say that patient that had the total knee in the very first few slides, let's say that their staples come out, their wound is completely healed, they've been cleared for pretty much all different types of activities that are appropriate for therapy. We want to take that knee and we want to perform knee flexion, range of motion, and stretching to the quadriceps muscles so that we're pulling and we're giving stress to those tissues so that collagen will line up with the moment or the movement of that stress. So if we perform lots of knee flexion range of motion, we're going to take these randomly oriented fibers and we're going to stretch them into basically a nice parallel pattern so that we get good flexibility. Now for the very surface skin, the collagen fibers are kind of all over the place, but if we're trying to look at something like tissues underlying the skin, especially tendons, ligaments, things like that, they need to be in a nice parallel orientation, and the way that we can really kind of have an input on that is through our external stresses or internal stresses like exercise and those kind of things. But again, we're trying to think of increasing muscle tension, we're trying to increase joint movement, we're trying to increase soft tissue loading, and maybe even apply some type of thermotherapy to the area to improve elasticity of the skin. The last thing that we want is for a lot of scar tissue to form underneath the surgical site or on a wound or fill in the wound bed with this scar tissue. because again, it's just not going to be healthy, normal tissue. It's not going to respond to stress the same way. It's not going to respond to temperature changes the same way. So we want to do everything that we can, using modalities, using passive range of motion, using things like therapeutic exercise to help increase this load on the tissues in an appropriate manner. One of the best ways to do that is through low load, long duration stretching, which we're going to get into in semester 3. It's one of your skill competencies in this program, stretching for the lower extremity, as well as the upper extremity when we get to semester 4. So we want to provide low load, long duration stretch. Low load meaning it's not too intense to where your patient is not able to tolerate this. Long duration for us, usually meaning a minute if we're in the clinic, but there are bracing options out there where you're going to be keeping that sucker on for extended periods of times, 2 hours, 3 hours, 4 hours at a time to really let that tissue stretch out. So again, we want to make sure it's an appropriate load to the tissue, aka the low load that we're talking about here, but it is completely essential for the formation of that soft tissue in this maturation phase. So let's look at chronic inflammation. We've kind of talked a lot about this acute phase of inflammation and acute injuries and things like that. But what happens whenever somebody is facing chronic inflammation or they have some kind of chronic issue? They may not present with the same exact signs and symptoms that we looked at earlier. There's still going to be probably loss of function, but it may not present, red, tons of edema present or anything along those lines. But still underlying, we have inflammation that's present, which leads to tissue destruction and prolonged healing, essentially. And whenever we see this kind of chronic inflammation, this is where we start to really see a lot of increase in scar tissue and adhesion formation. So this is why it's super important to, allow for that inflammatory period to take place, but we want to make sure that it's not hanging around for too long, right? We kind of saw that acute phase lasting 1 to 6 days. If it's hanging around for 2-3 months at a time, that's not good for our body, right? This is where we start to see increased scar tissue. Our body, if you think about it, when we're in a state of inflammation, our body is constantly breaking down tissues. We're in this kind of catabolic phase, and it's trying to repair itself constantly. Well, it's just going to lead to increased scar tissue formation and that adhesion formation, leading to range of motion and loss of function. Okay. So again, the reason that it happens is because we're in a chronic state of inflammation. We don't get that nice healthy collagen. We don't get that nice scaffolding essentially for that collagen to form on top of. Maybe when we're trying to provide tension to the area, we're just exacerbating the symptoms and we're kicking them back into almost like an acute phase of injury. So we need to be really cautious for our patients that have chronic inflammation and aware of what the response may be long-term for them. Okay, so some of the local factors that are affecting the healing process, again, include location. So for the patient that has a total knee replacement, obviously the knee extends, it bends, or we flex the knee. If it's over that area and we're constantly putting too much pressure on the anterior portion of the knee via knee flexion, we may be just kind of ripping that band-aid or that fibronectin type lattice, that little formation, that network that looks like a spider web. We may be tearing that apart and starting from scratch all over again. If there's infection, that's going to delay our wound healing process. So again, very important to look for that purulent drainage if there is infection present or suspected. Vascular supply, that's why angiogenesis is so important. We're trying to repair those capillaries that were injured during that acute phase. We need blood flow, we need oxygen, we need nutrients to help support healthy tissue healing. External forces, this is why we have to be really cautious as providers, right? We can't provide too much stress to the area, whether that be through range of motion or massage type techniques, anything like that. And movement kind of referred back to what I talked about with location. Too much knee flexion causes that wound to not heal properly. Other systemic factors include age, disease, medications, nutrition. So again, when we think of nutrition, vitamin C essential for collagen formation. When we look at medications, we talked about two main ones that I want you to know for this chapter, NSAIDs and corticosteroids. We learned that NSAIDs have the ability to slow down that healing process. They can lead to other issues like GI ulcers. We saw that corticosteroids can kind of do that same thing, right? Delay wounds healing, can lead to tendon and bone breakdown and potential injury. Disease, we looked at some of those diseases like rheumatoid arthritis. We looked at diabetes, systemic lupus. Those all have a major factor in how well this person heals. And then, of course, age is never in our favor. The older we get, the less effective our body is at tissue repair, the less effective our immune system is. So all of those would be more of those systemic factors that would, really limit how well we're going to heal in this long-term process. Okay, let's kind of finish up here. We're getting close to the end. Healing of specific musculoskeletal tissues. We're going to get into far greater detail when we get into our therapeutic exercise courses. So let's talk about cartilage first. So cartilage, if we have something like osteoarthritis, I know this says months to years here, but cartilage really isn't responsive to healing process because there's not a lot of blood supply to that particular type of soft tissue. So what are your options if you have significant osteoarthritis of the knee? You can live with it. You can try PRP injections or something along those lines, or you can get a joint replacement. Now, there is some subjectivity to these other numbers here with tendons and ligaments. I kind of went for the long-term approach, so we'll just take this with a grain of salt here, but I'm really thinking of getting back to full strength when I put these numbers up. So tendons, anywhere from 3 to 6 months, ligaments, 6 to 12 months, and the reason that you're going to see longer healing times with ligaments is because, again, they don't have a vascular support, or they're much less vascular than the tendons are. So if you think about it, right, tendons go from the muscle belly to that musculotendinous unit where they insert on the bone. The muscle has great blood supply. Therefore, it's going to have better blood supply to that tendon. The ligaments are just bone to bone, right? Now, the bone has good, healthy vascularity, but the ligament doesn't get that nice vascular response. So ligaments are going to take a long time to heal. A good example is if you've ever had an ACL tear or any type of other ligament damage that really warranted reconstructive surgery. You may be up and walking around in 8 weeks, 12 weeks, but you're not going to go back to your previous level of activity really until you're about 8 months to a year out. And sometimes it may even take longer than that. There's a lot of good research coming out for early mobilization of tendons and ligaments, especially in like a rotator cuff tear, which is more of a tendinous ligament. Making sure that we are, again, introducing some kind of stress to the tissue that is tolerable. So we're going to learn all about this in our therapeutic exercise class, but just know that early mobilization is often seen as good. There are certain activities, motions that we want to avoid for sure, but early mobilization is generally a good thing for healthy tendon healing. Also, we have this little discussion about extracapsular versus intracapsular ligaments. So we'll not really get too involved in that, but you should definitely know some of those kind of structures. So something like the MCL is more of an extracapsular ligament. It's not inside the joint. of that tibiofemoral joint. But something like the ACL or the PCL would be more of an intracapsular ligament. It's deep within that joint, stabilizing that joint. Okay, so we'll talk more about those in our TheraX class. We finally get to skeletal muscle. Typically 2 to 6 weeks is a normal healing time here, and really kind of on the upper end of that, 6 weeks, maybe even 8 weeks is something that you would expect. And then we get to bone, which is about 6 to 12 weeks. So if you've ever heard somebody say, I'd rather have broken the bone than tear the ligament, well, here's the evidence right here. You can see bone heals much faster, and again, it's because of the vascularity to the tissue. That's what makes the biggest, that's the biggest factor here, right? So breaking a bone, although terrible, risk of deformation if it's severe. There's always a risk of a compound fracture, all those things, but typically, breaking a bone, we can fix that. It'll heal much faster than ligaments or tendons. Okay, last few slides here. Now we're talking about the different phases of bone healing. So we have induction, inflammation, soft callus, hard callus, and the remodeling stage. So this is something that you'll have to study. You're going to have to know, how to identify which phase a patient is in. And I do want to bring you down to this second to last bullet point here, where it says hard callus. Oops. The hard callus, I can't go back, but the hard callus is what we typically see with radiographic healing. That will definitely be a quiz question that you'll see in the future. So if you ever see, a scenario on an exam that says your patient is has returned from the physician or something along those lines, and the report says radiographic healing noted, you know that it's in that hard callus phase. I know that's a lot for this chapter to memorize, but super important that you make sure to study that inflammatory phase. That's going to be kind of the bulk of what you'll see on exams, are all those different responses. Again, vascular response, hemostatic response, immune response, and the cellular response. So make sure you know those ones, how to identify them on any quiz, and what's happening physiologically there. Okay, I hope this is helpful. If you have any questions, feel free to reach out to me. Thank you for listening, and I will talk to you soon.